Welcome. Thank you for joining us for our virtual neonatal crash course this evening. The idea of the course is to give everyone either a first introduction or a refresher to some practical procedures of neonatology and some of the theory around it. I just want to thank the London School of Paediatrics for hosting us this evening. And thank you to my co-organiser, Arame, who's been fantastic. Katie Bailey at the London School of Paediatrics for supporting us in setting up the course. And of course, all of our consultant speakers who you will meet over the course of the weeks. So we're going to be starting this evening with a talk on intubation and ventilation by Dr. Sandeep Shetty, who is a consultant neonatologist at St George's Hospital, who also lectures for St George's Medical School. Arame, would you like to go through some of the housekeeping just before we start the talk proper?
Of course. Let me just go through. So, yeah, as Alex said, we're just going to be giving a whistle-stop tour of the basics of neonatal airway management and ventilation. Let me see. Yes, so some general housekeeping before we start. So everybody, please kindly put your microphones on mute. And if you have any questions, please type it in the chat. And I'll go through them whilst the talk is happening, and we will endeavour to answer them in the Q&A at the end. And yeah, so we have a maximum capacity for this session of 250 participants, and it's run in conjunction with the London School of Paediatrics. So in the event, if we, in the possibility that if we do reach overcapacity, then we may ask people to kindly leave if you're not a paediatric trainee. But please be assured that this session will be recorded and will be put up on the LSP website. But yeah, we welcome external trainees as long as we are not over capacity. Thank you.
Thank you for that introduction. Can I just confirm that you can hear me and you can see the slides?
Yes, thanks, Sandeep.
Perfect, thank you. Thanks, Alex. So in the next 1 hour or so, what I'm going to do is talk about intubation and ventilation. And I can't, let me just see whether I can share my slides, and then it becomes easier for me to move on from one to the other.
I can see somebody's slides, but I don't know if it's Arame's or yours, Sandeep.
It's mine, but I can.
It's just that I can probably move on to the next slide easily rather than asking you to move on. Let me just see if I can do that. Can you stop presenting, and then I can see whether I can take over from there? Can you see my slides? Let me see.
Can't see any at the moment. I think Arame has stopped sharing.
Let me see what's happening. I'll give one final go, otherwise we'll just do the way we did it.
Okay.
I'm sorry, shall we do it the previous way, and then I can see I'll ask you to go on to the next slide, if that's okay. I'm so sorry about that.
That's fine. No, that's fine.
Don't worry,
Dr.
don't
Shetty.
worry.
That's fine.
I'm so sorry for the delay in the start. So basically, I work as a consultant neonatologist such as St. George's Hospital. My particular area of interest is mainly respiratory physiology and looking into invasive and non-invasive ventilation. So that's my area of interest. So in the next 1 hour or so, if you can go to the next slide, please. Generally, I was going to do mainly talking about neonatal intubation, and I'm quite. That will be 50% of the talk, and then we'll quickly whiz through basic mode of mechanical ventilation, that is basic ventilation modes, and I'll talk about high frequency mode of ventilation as well. I've got a couple of examples in terms of blood gases, and we can look through case studies, and hopefully we can make that as an interactive session, and we can use the chat function to get a better understanding of what you would do if you were in that kind of a situation. So when you talk about neonatal ventilation, so the number of reasons you may want to intubate this patient. So the primary, as you know, that when it comes to newborn babies, is particularly respiratory failure. That would be a primary reason why we'd intubate a baby. We also know that a big chunk of patients would be either term babies, that is babies more than 37 weeks of gestation, or preterm less than 37. And as they are more preterm, that you have less surfactant that is produced, and hence they would probably need some kind of a respiratory support, either in the form of invasive or non-invasive. There could be intubation needed if they're very premature. You may want to give surfactant. And there are newer ways of administering surfactant and not just intubating a baby. You could think about processes like LISA or LISA, where we pass in a catheter through the vocal cords under direct provision and give surfactant over a period of time between 4 to 5 minutes. There are specific conditions where you may need to absolutely intubate. For example, a congenital diaphragmatic hernia. We know that the diaphragm, which is a muscle separating the chest and the abdominal cavity, there is a weakness. There is and there is herniation of the abdominal contents into the chest wall cavity. In that case, you absolutely have to intubate this baby and connect to the ventilator straight away, so that unstabilize this patient until the respiratory function, pulmonary hypertension gets better, and the baby is actually stable for surgery. There could be anatomical malformation, let's say Pierre-Robin syndrome, where there is a genuine problem with rectogapnia, genuine problem with the actual anatomical structure, keeping the airway open, where you may need to ventilate this baby. Or let's say the baby was born in a very poor condition, like say, for example, a hypoxic ischemic encephalopathy, in which case you may need to consider initial ventilation, because the baby is not the respiratory center, which is your brain, which is present in the midbrain. The center, it may not be, it's not really good enough in terms of actually being to regulate the respiratory function, and you may need to intubate in the initial stages, or if the hypoxic ischemic damage is significant, is bad enough, you may need to intubate for a prolonged period of time and take it from there. Systemic conditions like sepsis, general anesthetic, in a patient who needs to go to theater, of course, needs to be intubated for the management of this condition. So are there any contraindications in neonatal ventilation? Quite frankly, there are no absolute contraindications, but what I want you to have a understanding is basically, if you're anticipating a difficult airway for whatever reasons, it may just be that you've been told the airway previous intubation was very difficult, or you think that the syndromic association or the peer rebound syndrome, or there is some kind of an anticipated airway anomaly, then it is best to be as prepared as possible. Now, in that case, you may need to consider what is that, how do we prepare myself? So in that case, like, is there a difficult or an advanced airway pathway that is already installed in terms of, that is already in place within the unit, or escalate to your senior colleague and see how do we manage from there. Now, preparation is absolutely key. And there is usually, when you've decided on the course of, if there has been a decision on intubation, then it is also important to think about the choice of intubator. So always have a rough understanding, is like, if you haven't intubated before, are you the right person to be, it's quite often within the unit, there will be a discussion about who is going to intubate. And we'll talk about a bit around that in terms of what, who should be the first person to offer. Well, would that be as a routine, but the person who is the junior most colleague within the team, who needs some practice with intubation, or the thought process around intubation? So we'll come to that point in a while. Escalation planning. What happens if the initial intubation is not as planned, and how do we prepare ourselves? Now, what kind of equipment that is absolutely needed? What are the pre-medications? What is the ET size? And some tips around the length of ET tube that needs to be inserted. Now, it has, over a period of time, so now, so certainly since when I was doing neonates as a trainee, I certainly feel that I was intubating a lot more than what you're doing currently in the neonatal on the neonatal unit. And certainly delivery room intubations have become far fewer, because if it's a preterm baby, there are other modes of ventilation that are done. Let's say if it's purely just because of surfactant deficiency, a borderline preterm baby anywhere between 26 to 29 weeks of gestation, you may want to consider LISA, for example, or administering surfactant, or you may want to do non-invasive mode of ventilation without even offering surfactant in the first place. So there is a general shift from just intubating and ventilating, and intubations are usually reserved for the baby who absolutely need it, and that's why you may not necessarily get as much chances as an opportunity to intubation within delivery room, within the delivery suite, or in theatre, for example. And also, it's just a thought process around, if intubation is needed in delivery room, and where your timing from the time of birth and intubating or securing an airway is absolutely key. It's just having an open discussion. Should that be a senior member of the team? Or if you've done it far too many times within the unit, you've got enough practice and you're fairly confident, in that case, I would say put yourself forward for a delivery room intubation. But if there is a team discussion saying that the team, a senior most person or the middle grade would like to do that intubation, personally try and understand the situation in terms of why the thought process is there, rather than putting yourself into a position where risking the actual resuscitation process for a preterm or a term baby who absolutely needs that airway secure airway in that position. Most NICU admission intubations are quite often, they've had some kind of a tube in the past, or it has been an accidental extubation or a planned extubation or a planned elective intubation. So in that case, it is it would be a right place for you to offer yourself, and quite often what happens is the middle grade or the consultant will probably say, would you like to have a first go? And it's the right kind of environment for you to put yourself forward, where you have a lot more confidence in the system about about the intubation or about the procedure in itself, and also a reassurance that the entire team is there to support you. Now, a word around just because there are times when you're actually intubating or putting yourself, you might just find there are far too many people. There are nurses, there is a middle grade, there may be a consultant, and there will be, there are at least a couple of other nurses who are drawing up medication. So you actually, in a way, you become, you probably are in the limelight of, a lot of people observing, and that might be quite unnerving into actually starting the process. But just be reassured, there is enough support system. You are not primarily responsible for that intubation, and if things go wrong, there is the next person to step up and say, I'm going to take over from here. So try and limit the number. So there were almost always there's some kind of a discussion as to how many attempts are you going to give. In that case, it's very likely to be 1 or 2 attempts. But even if the first attempt is looking at it on a direct vision and looking at what are the structures that you're looking at, what you're aiming for, that in itself is a good experience. Or holding a laryngoscope, where you may have practiced on a mannequin previously, but on an actual baby, it might be ever so slightly different. That in itself, that initial experience is all built. It's not just getting the tube, but getting what the preparation would be, getting a feel of what the preparation would be, or what to look out for. What are the monitors that you need to actually keep a key focus on, so that you have a fair bit of an idea. And sometimes you learn a lot when others are intubating, just observing what are the steps that are undertaken. What is the escalation planning that is done, and how do we try to ensure there is no cardiorespiratory instability? So quite often there is always a preparation phase, and there is a discussion around around escalation planning, and if at all you're taking a bit too much time in between your attempts, or when you're actually visualizing, then there is a timekeeper who will say like the heart rate is going down, or there is a senior nurse who would say the heart rate is actually now 100 or 90. Quite often it's the heart rate which drops first, and then your saturation is also dropped, or sometimes it can happen simultaneously. But having that rough feel when to come out, to go back and back the baby, these are all important skills that you will hone with your experience, and with each experience it will only get better and better with how we progress. Now, equipment-wise, so there will be the most common equipment that you will, which is commonly you will be looking at, is your neopuff ventilation. So if the baby is not already ventilated, then it's very likely that you'll have neopuff ventilation. Appropriate size mask. There are 2 different makes of mask. One with the and there are different sizes of mask as well. If they're very premature, it's the ensuring the neopuff is basically the middle picture that has been put in. I'm not really sure whether you can see my cursor. And that in itself will have a PEEP adjusted to it, and checking your equipment. Absolutely essential is put your air flow up, and keep your PEEP and try what your PEEP pressures that has been set at. So if your PEEP pressures are at for a preterm baby, you may want to, or it's not like giving you inflation breaths. If these are babies who have had some kind of a ventilation support, they may not need as much high pressures. Ensuring there is a safety netting, you may need just 20 or 25 of pressures, and on the PEEP that is your positive end expiratory pressure, is absolutely key that it is not very high. It's not uncommon to have inadvertent high PEEP. Let's say when you go into a scenario, you have your PEEP in your nose nest, you haven't really checked it, it is actually set at 10. In that case, you're not going to ventilate this baby effectively. Although your tube is in, you may not necessarily be able to inflate the lungs properly, or you have it at effective gas exchange that is needed. As a backup, each incubator space or in resuscitation, you have bag-and-valve mask with a reservoir in there. That's part of all your resus kit. And if you ensuring your endotracheal tube, again, endotracheal tube could be different in different hospitals. So certainly there are there's Portex tube, which is on the left hand side. There's a standard Vicon tube, or there was Coles tube, which is put I've put a picture of that in the lower, that's the light blue one. Now, all of these, the Coles tube is basically, it's only at the tip it is narrow, and beyond that it is slightly wider. The aim is that basically you don't have slipping of your each endotracheal tube further and beyond the vocal cord, because there is some kind of there is a restriction because the tube is widened. Some units prefer that, and the thought process is the accidental extubations may not be as much. And there is a stylet that is inserted within the endotracheal tube. Now, stylet within endotracheal tube is not always necessary, but most neonatal units have gotten in this policy of introducing that. In that case, it's important that we've prepped up your endotracheal tube absolutely correctly. Stylet almost never should be crossing the if you look at the three pictures that I've on the right lower quadrant, then you have the stylet at different positions. So you have right at the tip, just at the level, above the level of the Murphy's eye. Murphy's eye is just a small hole that is present at the tip of the side, on the side of the tip of the endotracheal tube, or well above the Murphy's eye, or just to the. So essentially, the idea of introducing stylet is basically to have some kind of stiffening. It is not malleable. Your endotracheal tube is not malleable, and the idea is possibly to have a safe direct path going through your vocal cords. Now, try and be aware that if the stylet is not really positioned properly, then it may be difficult for you to actually release the stylet if you've bent at the tip far too much. So generally, most clinicians tend to angle it in such a way that it's slightly curved, not a straight endotracheal tube. But it may just be that you've angled it in such a way that taking out the stylet after intubation is challenging, in which case I've certainly had one paper published where the outer sheath of the stylet actually got stuck within the endotracheal tube, and which actually blocks the entire ET tube as such. The other issues with stylet is basically sometimes you may want to, if it's not angled correctly, you may not be able to advance your endotracheal tube, even if you've got it within your vocal cords. And in that case, you may need to take out the stylet while still within the vocal cords and slowly advance your endotracheal tube after that, because it's just is obstructing in such a way that you're not able to advance it. Laryngoscope blades, there are different sizes. They move on from 00, 0, and 1. The extreme premature baby, you may need to think about 00, and it's check your batteries beforehand. So quite often it's usually patient specific. So more recently they're all disposable plates, so you don't tend to use the same laryngoscope. Even if you tend to use it, it's very likely to be kept for the same patient. We don't, almost certainly would never be used for another patient just by cleaning and moving on to another one. Can we move on to the next slide, please? See, further in terms of the other equipment to keep in focus is your EtCO2. So it's your end-tidal CO2 marker, which would mean making sure that the endotracheal tube is in good position. Would be one of the ways to, there is, I've put in a picture of one of this, but what at St. George's, we have a slightly different one, which looks differently. And we know now with NLS, so this session is not NLS training. So we know that with NLS, instead of the Giddel airway, now that has been replaced by LMA. So all our research trolley will now have LMA, having a fair idea of how to use LMA or an iGel. So the iGel is the one in the middle. LMA is the one on the left. So only difference between element in the iGel, LMA, you have to insert a bit of air, and it's all marked. The smallest size is size 1, which would mean that it will look after babies between 0 to 5 kilos. So quite a wide range. It's almost certainly won't be very effective in extreme premature babies, but say a term baby, if there is difficulty in getting that chest expansion, and you know that there is no block in terms of secretions or a mucus plug or anything, then LMA insertion to have that chest rise may make a difference. Now, iGel, it works in a difference. So the tip having being slightly green, which it is thermosensitive. So what it does is basically it sits at the level of vocal cords. It molds around your vocal cords to have an effective seal. So this is basically it will have a bit effective seal. You don't have to insert in the air. And generally, what happens is you do this under direct vision. So you have your laryngoscope. Blade, you do it insert your iGel on an LMA, and it sits at the level of the vocal cord, and then connect it to your neopuff ventilation, and then and look for chest expansion and continue the ventilation. I must agree the LMA practice is not that common at this point, but the having a good knowledge about LMA and insertion is absolutely key, and that's part of your NLS course as well. Suction catheter, important to remember that most delivery suite will have a Yanker. Yanker will have a suction catheter, which is either kept between 80 to 100 of suction power, and you do need to occlude the opening on the Yanker catheter for effective suctioning. So if, of course, there is ongoing resuscitation required, then you will move on to more malachite catheter, suction catheters, which is, if it's a thick meconium, you may want to select a black catheter because that's slightly wideable and will have a lot more suctioning. Stethoscope at all points is absolutely essential because any intervention that would do in neonatal resuscitation, the first response that you get is your increase in your heart rate. So if your ET tube is in the right place, then you will see automatic improvement in heart rate followed by your saturation. Of course, you're looking at other parameters to see whether your endotracheal tube is in the right place. And I'll come to that in a couple of our slides later on. Now, there has been a lot more use of video laryngoscope, and we found at St. George's as well a great use in terms of teaching and training. So we've actively started encouraging trainings to use video laryngoscope. But the downside is basically when you go to a unit which doesn't have, if they don't have video laryngoscope, then you haven't had ample practice with the traditional way of intubating and ventilating. Now, so a rough experience with both is absolutely essential. Now, the Accutronic is commonly used, but the problem right now with Accutronic is basically the company is shut, but this is the only video laryngoscope who have 00 blades. So we've got on the neonatal unit at St. George's, we've got both Kaleidoscope and Accutronic. Now, Kaleidoscope is disposable blade, and Accutronic is more autoclaved blades. So, you know, each blade is almost up to 1,000 pounds. So be careful of the blades. And 000 is absolutely, you know, once we use, we send it for autoclaving and comes back to you. The technique between video laryngoscope and traditional intubation is ever so slightly different. Now, how is it different? Now, video laryngoscope and conventional, you might there are different views that are put on the on the slide. So if you look at let's say the not the top two photographs, but the one below, the video laryngoscope may well obstruct your view. So the aim of video laryngoscope is a different technique. Is basically you're viewing your vocal cords on the screen that is displayed, and it's absolutely essential that you keep the machine just opposite to yourself, and not make an attempt to look at the vocal cord using the laryngoscope. So your vision of your vocal cord is the screen that is displayed. The handle of a video laryngoscope is heavier, and so it's and yet again, all laryngoscopes are left-hand instruments, even for a left-hand person, and and hence getting a good view. And sometimes you may need an additional help of a colleague who may just help you with the cricoid pressure, so that the vocal cord is easier to visualize. So it's much easier for you to visualize. And once you've had a good vision, then either passing a LISA catheter or an endotracheal tube becomes easy. It's a technique that, again, advancing. Once you have seen the vocal cord, you passed your endotracheal tube closer to the vocal cord, sometimes you may need to maneuver ever so slightly in such a way that the tip then enters the vocal cords and then advance further. So it's a technique that is that you have to teach yourself, whether it's conventional or video laryngoscope. But if there is ongoing video laryngoscope within the unit, then you know. It's important that you have that experience. And the other key advantage of that is basically every other member within the team who's observing you is very confident the tube has passed through the vocal cords, because everybody else can see. And one of the nervousness that I have as a senior member when somebody else is intubating, that is I can't see what you can see when you're making your first putting the blade in, and you may not necessarily, it's not very clear whether you're able to see the vocal cords. Are you identifying the structures when you're doing it for the very first time? It's quite hard to explain what to look out for. Are you far in? Do you need to come out? And it's those kind of information is often easier with the video laryngoscope. Now, guide to how deep you insert your endotracheal tube. Now, there are rough measurements. All of us, you know, have some kind of an app on your phone. So Neomate is a very common one, where you put in your gestation or your weight, and then it tells you what each endotracheal tube and what the length would be. But general dictum is basically, so if it's a, you know, I roughly have this in mind, it's basically if it's a less than 1 kilo baby, then it's usually try not to go beyond your 5.5 and 6. 6 is your cutoff. 1 to 2 kilo is anywhere between 6.5 and 7. 2 kilo above, you're looking at 8 centimeters. But there are other ways typically described in this way, whereas you take your nasopharyngeal length from the base of the nasal septum to the tragus and add 1 centimeter or 2 centimeters. Now, it isn't very common to do nasal intubation in the neonatal group, but certainly there are some units who do only nasal intubation, and it's not uncommon for a bigger baby where oral intubation is converted to nasal, that purely from comfort point of view. In that case, it's not uncommon for an oral intubation to happen first, and then a nasal tube is introduced, and you use a forceps to advance it through the vocal cords thereafter. So again, a rough guide. Generally, as far as possible, your endotracheal tube size will vary anywhere between 2.5 to 3.5. We are very wary of, although your neonate or app might say use a 4, we tend to not to use 4 unless absolutely essential and there is a definite leak on the ventilator, because you're worried about subglottic stenosis and the tight fitting, of course, snug fit of the ET tube, and so we try and avoid size 4. It's usually the sizes that are used on the neonatal unit is anywhere between 2.5 to 3.5. If, of course, there is difficulty in inserting a 2.5, there is size 2 that is available, and you're very welcome to insert that as an emergency, and we tend to upsize it on the neonatal unit once the baby is more stable. And this is a rough guide based on gestation as well. So it's very likely, again, as I said, the less than 28 week, a big chunk of them will only need 2.5. As I said, we do not want a snug fit. We almost never use tube with a cuff. In fact, that's mainly because the anatomy of a preterm return baby is very different from a child. And it's important that you don't use any endotracheal tube with a cuff, or even if that has been used accidentally, not to inflate the cuff, because there is high risk of subglottic stenosis in these babies. Now, coming to pre-medications. Now, we've spoken about equipment, we've spoken about you as an intubator, and we are talking about pre-medications. Now, commonly, the drugs that is used is a combination of fentanyl and dexamethasone, with or without atropine. So that's the start over there. Now, and it's very often the fentanyl is given first. Atropine is drawn up but not used, and dexamethasone is given just before the intubation process. Now, it's some units may do slightly different. If you're working in pediatric intensive care or you've been exposed to the medications that are absolutely very different for intubation. There isn't much work done around pre-medications, and it's very common for neonatal units still sticking to what we actually know the best or that's been used. But what is certainly I've noticed is like we don't understand the drug completely. We're using fentanyl, we're using atropine and dexamethasone, and I thought it's important to cover how does it act and what are the side effects of each of these drugs, so that when you actually come across these side effects, then you know it is very likely to be intubation-related drugs. And it might just take a while for it to normalize. Now, the dosage of fentanyl is 5 micrograms per kilo. It's very common for a big chunk of units have moved on to pre-filled syringes, so that in an emergency it's easy, and there is a chart which gives you the weight. If this is the weight and this is how much you have to give in terms of mils, so there is no drawing up, and it's all ready for you. And it's very common in a delivery suite sort of a management arrangement, because you have a rough idea of the weight. You haven't weighed this baby, so you draw up the medication as a pre-filled syringe, and that is given. Fentanyl as such is given at 5 micrograms per kilo, and it's quite a high dose. So in a LESA procedure where you don't want the baby to stop breathing, then you may need to consider a very small dose. So that would be anywhere between 1 to 2 micrograms per kilo. And sometimes we don't, as a just sedation or pain relief measure. Atropine only if there is some kind of event with low heart rate. In that case, you can give atropine. And dexamethasone is just given once you've given you a fentanyl for a reasonable given, and you know that it's been at least 1 or 2 minutes, and then that's your time for your dexamethasone to given, and it's 2 milligrams per kilo, and which is given as a bolus. So how does fentanyl work? So it's given over as a slow push. It's always important before you prep up your decision, when you make the decision about intubation. If it's you have a working cannula, intravenous cannula, and if you feel that this is an emergency IV cannula that's not working, and if there is a long line, that also can be used. But the only difference is when the nurses are preparing the medication, they are preparing it in a aseptic manner, in a sterile way, so that it can be administered through the long line. Now let's concentrate on those side effects that's written here. So we've got apnea, hypotension, CNS depression, and chest wall rigidity. Now, chest wall rigidity we do come across on and off within the neonatal unit, and that information is important when this baby gets intubated the next time around in the future. So in that case, you give you probably may think about half the dose of fentanyl rather than the full dose of fentanyl, because there has been chest wall rigidity with the previous intubation, and making it almost difficult to actually inflate the lungs or get that chest expansion. You have to go up the pressure significantly. And also, all of these medications are excreted, are renal excreted. So in that case, if you are oliguric, your creatinine levels are already high. There is the consideration whether we need to think about, is the dosage, can I reduce that dosage to 2 mics per kilo instead of 5 mics per kilo? I have to be honest, but we don't, in an emergency, we don't think as much, but having an information about these kind of side effects and thinking about renal excretion, thinking about chest wall rigidity or causing a knock-on effect with your blood pressure, these are all important aspects of giving any of these medications. Atropine. Now, atropine is, so when you have your blade in there, so it acts as a vagolytic agent. So there is vagal inhibition. So in that case, atropine acts as a vagolytic. Your heart rate, which is significantly lower, which is dropped down to 30 or 20. In that case, you may need to think about atropine. Quite often, the heart rate dropping is, if it's vagal inhibition, then as soon as the procedure is done, it comes back up. But of course, you can't have this very low for a long period of time. That's when atropine is kept as a backup. It may just be that once atropine is given, the heart rate might be, post-procedure, heart rate might be very high for a very long time. So it can last up to a good 1 or 2 hours. In that case, it's just an effect of atropine. You just need to allow time for that to come down. One of the knock-on effects is urinary retention. And of course, if there is, as far as possible, we don't use atropine as a routine in your newborn intubation. So sucks. Succinylmethylene as a paralytic agent, it works as a bolus between 10 to 20 seconds. Onset is very quick. Cardiovascular instability and hyperkalemia. Now, once we've spoken about preparation, we've spoken about equipment, and we've also talked about having a pause. Now, the absolute essential thing is, when I say pause, basically that decision of intubation has been made. The group, there is, you've checked all your equipments, as I said before, in terms of the mask, above, what is the, who's going to scribe, who's going to prepare the medication, what is the purpose of intubation, and also having an effective nasogastric tube. With all this, basically, because you're new puff ventilating, there is a bag and valve mask ventilation, so you want to deflate the tummy on a regular basis. Otherwise, there will be, you may not be able to get that chest expansion and effective gas exchange, making it all the more difficult to intubate because your SATs are not, baby is not pre-oxygenated, and that's why it's important that you're not able to achieve, then it becomes an emergency intubation, which beats the whole purpose of actually planning and thinking ahead, basically. It's all, at all points, because you're taking off your incubator lid or opening up bringing the baby out of the incubator, temperature at all points. So there is facility within your incubator to raise it up completely, or even cover the baby so that just the head end is opened, and you cover the head in terms of preparation with a hat, and then introduce your then proceed with your intubation. So optimize. So what? How do we plan this? So once the decision is made, optimize. So optimize would mean there is already the baby would have been some kind of a non-invasive support on the neonatal unit. In that case, let that continue until you've given your medication. Take over, put it back on mask, ensure that the NG tube is in. The nurses, the bedside nurse would then aspirate the tummy while you're back in the baby. Medications are given. If your positioning, if your chest expansion is not very good, reposition. Consider your 2% jaw thrust technique, and ensure that is effective chest expansion. And then, when the time is right, when your saturations are very good, then go ahead and then give your go with your intubation. This is a slide, again, I've taken it from an analyst. So essentially making sure there is neutral position, good seal around the mouth, good jaw thrust. Note that you're not actually pressing on any of the soft tissue areas. The middle finger is at the chin level, and that giving you effective chest expansion. Now, once you proceed with your intubation, you're really looking at your view, and that on the right-hand side, there is, I must agree that is not common practice for us, but try and just make sure you're not impeding the upper lip. Upper lip injury is very common. Try and save that upper lip when you try not to injure the upper lip. Because they bleed very profusely if there is injured, and in that case it may obstruct the view with blood. So it's important that you have a good view. Once you've had a good view, only do suction only if there are secretions. Otherwise, you do not need to do suctioning. This is the view that you're looking at. You're looking at your vocal cords. Epiglottis is something that would come out. Once you've seen your epiglottis, then in maneuvering technique so that you lift the epiglottis, seeing the vocal cord, and ensuring that you've got the glottis completely open, and inserting your endotracheal tube. So once you most endotracheal tube have got a black mark in there, which is where you need to stop. But alternatively, you can adjust your length of the endotracheal tube at the lip level. After you've inserted, we are really looking at what your whether the tube is in. The number of ways of making out where the tube is in. So first one would be, which is commonly used, is EtCO2 detector. There is an effective color change. I get very confused because it's not something that we commonly use at George's. I'm very confused if this is given, ensuring it's the bright yellow color and not the pale yellow or the beige color, which does not mean that the ET tube is in. And of course, if there is cardiovascular arrest, so if there is no cardiac output, you may not necessarily get the color change. So if you're in that case, if you're absolutely certain you've got the tube in, your nasogastric tube does not have any air coming out, you may need to proceed with your chest compression. And once there is some kind of a cardiovascular stability that is brought, then there might be a change in your endotracheal tube. The other ways which we commonly do on the neonatal unit is connecting a EtCO2 continuous monitoring, which is displayed on the monitor, which will show if there is any kind of CO2 wave pattern, that means that the tube is in. Fixing, there are a number of ways. So different units will have different practice. What is important that you have a feel about how ET tube is fixed when you start with the neonatal unit. The fixing is quite confusing. Quite often there is hat used in most neonatal units. There are the units who don't use a hat at all, which is again good. It's safer for the ear. There's no tight pressure around the ear. There is no, so that it's better use of. It's easier to monitor pressure source, but all in all, try and make sure you are familiar with how the unit endotracheal tube is fixed. So, you're really looking at placement. So once your endotracheal tube is in, you're looking at the heart rate increasing, effective chest wall movement, misting around the endotracheal tube, and maintenance or improving the oxygen saturation and bilateral equal air entry. And the other additional point I would say is if you're not getting as much air on your NG tube, these are all confirmation factor that the tube is in good position. And of course, you're looking at ETCO2 color change. Gold standard would be ensuring your chest X-ray, whether the tube is in. You're likely, you want it at least 1 centimeter above the carina. You don't want it too low because you don't want your air ventilation to be all supporting one part of the lung compared to the other. So you're really looking at and ensuring there is adequate documentation post-intubation, updating parents, and of course, if things have not gone well, if you were not able to intubate properly, then having that feedback or having that debrief session as how could I do that differently the next time, so that there is a learning process that is instilled into your mind. At all times, if things don't go after your intubation, if things go horribly wrong, there is sudden desaturation, you really ought to think about your doped mnemonic again. So you're really talking about displacement of your endotracheal tube. It's quite common to happen when you're actually fixing it. You've got it in, you've got your ET tube, everything looks good. At the time of fixing it, it's not uncommon at all for it to be displaced. And all that hard work is actually gone identifying that it's been displayed. So rechecking whether the color change is still there. Is there a chest expansion? Why is the heart rate dropping? Why is that saturation dropping? Or looking at other things like the pneumothorax, equipment failure, and obstruction because of secretions. Now, well, I've just put in a picture of a slide of our advanced airway algorithm within the neonatal unit. Now, every hospital has got what if things go wrong? How do we call or whom do we call? And it's important to have this handy or take a picture, but quite often it's kept in easy, it's quite readily available. And the reason it is ever so slightly different with each hospital is because it's more about who to contact. How do I contact? Is it a bleep? Out of hours, what is that telephone number that I need to contact? And these are the areas that you're looking at. Okay, now I am very conscious that I've really spoken a lot, and I've got conventional ventilation and high frequency ventilation to cover as well. And I'm just thinking, I just wanted to ask the organizers if I can actually go overboard and go around 15-20 minutes overboard, because I know it was meant to be a 1-hour talk.
I'm happy for you to go on. Yeah. So I don't have any, I've looked at the rest of the presentation and it's really interesting. So I'm sure it'll be very useful for everyone attending to have a listen to it.
Okay, so how should we leave the questions? Did you want to ask me questions as we go along, or is it getting too much information, or are you guys okay so far?
I think we can just leave questions till the end. Actually, it might be. I can't see any questions in the chat at the moment anyway. I think we can leave it till.
Sure. So really now we've spoken about intubation. I know I've taken quite a long time, but quite often I always felt like I hadn't. When I was starting off, I was picking pieces, small bits of information with every intubation that was going on. And that's going to be your learning curve as well. But what is important, I just always felt like, had I known all of this right at the beginning, then I probably would have been more clued in. And that's the reason, I thought the topic chosen for today was really interesting from that front, because I think it's in intubation per se. I don't think it's spoken about in that depth. Now, the next 15-20 minutes, I'm going to cover conventional ventilation. I'm going to talk about briefly on high-frequency ventilation, and I'm just going to go over a few examples if there is time to that. Let's say you've intubated this baby. Next scene that you're doing is basically connecting the baby to the ventilator. Now, the key parameters that you got to set at is basically you're looking at positive inspiratory pressures, and a positive end expiratory pressure, and you also set what you call as the I time and the rate. Now, these are the different parameters that the bedside nurse will ask you, what do you want, what mode of ventilation, and it's important that we have a rough understanding, and I'm pretty sure all of you have got some understanding around these parameters. Now, what is also important that you have a rough idea in how or what mean airway pressure means. As far as possible, try and concentrate on this number that is displayed on the ventilator. That gives you a rough understanding, and it's a complex measurement that is displayed. So it factors into your positive inspiratory pressure, it factors in your peak end expiratory pressures, your I time, and the rate. So it churns out a number that is displayed there, and it means that the higher the number. So if, let's say, you've got 14 and 15, you're actually saying that this baby is quite compromised. I need to worry about this baby. And if it's around 6 or 7, then you're actually thinking about, this baby is now ready for extubating. Should I really think about changing my strategy of ventilation, because I don't think this baby needs to continue ventilating. So it's a rough understanding as to, and as your mean airway pressure goes up, you're really talking about the lung disease is not too good, the sepsis is bad, or the meconium aspiration bad. Then in that case, you really need to look at what your gases are doing and then escalate from there. What is our idea about it, ventilation? Our key aim is to ensure that you're ventilating the lungs, or ensuring there is effective gas exchange while ventilating these lungs in the safe zone. What do I mean by safe zone? So you do want to prevent atelectasis. It's like a balloon with little bit of air is always easy to blow into. And if you over distend, you're not going to have good gas exchange. And if it's completely deflated, then you're likely to have what you call as atelectasis, causing more shearing forces, causing more ongoing damage. So it's important that we try and maintain your ventilation in your safe zone. And I'll talk a bit more about safe zone in the next slides. Now, positive end expiratory pressure is absolutely key in terms of ensuring your shearing forces or your alveoli does not collapse. Now, it is important, and that's why your PEEP that is set even in your resuscitation or when you're intubating is absolutely key. And even when you're extubating a baby, what we tend to do is basically set your PEEP, and keep your endotracheal tube until the last minute. Keep your non-invasive support covering your nostrils. Start that, and only then you take your endotracheal tube, because you don't want your alveoli to collapse. You want that extubation to be successful, and ensuring that there is effective gas exchange. So let's just summarize what So basically there are two modes of ventilation. So that one is pressure mode of ventilation, the other is volume mode of ventilation. Now, what does that mean? So we know that with volume control, with pressure mode of ventilation, we are not able to completely control the amount of volume that is delivered, and we know that volume trauma onto the lungs is significant. So what are the different So we're looking at what are the different pressure mode of ventilation, let's say. So we classified then as non-triggered mode of ventilation, which stands for your continuous mandatory ventilation. So this would mean that the baby is completely not doing much, is paralyzed. In that case, you put your pressures and pip and peep, and then tell the ventilator to do. So the ventilator take complete control. Triggered mode of ventilation would be your PTV, assist control, SI PPV, we'll talk about in a bit. And then SIMV mode of ventilation. And there are novel mode of ventilation like PSV, NAVA, and BiPAP. And we're not going to cover those topics now. What does CMV mean? So basically, as I said, it's a sick patient, it's a paralyzed patient, it's a sedated patient. In that case, irrespective whether, so you're basically having set pressures, rate, inspiratory time, and PEEP. And then once the baby is getting better, when there is more trigger factor that is involved, you support that trigger, you reduce your sedation, and get the baby to actually synchronize with your ventilator. So this is ventilator taking complete control of the situation. Patient trigger mode of ventilation. So basically, you're looking at, let's say, if a baby is actually triggering, then the ventilator will make every attempt to synchronize with that effort made by the baby, which would mean that every effort made by the baby will be synchronized, and it will try and help with effective weaning, and you're able to wean your sedation a lot easier. So if you look at this picture, so if the shaded portion that you're seeing in the middle, there is a trigger. So there is a trigger at those ends, and the pressure delivered is basically, if you're looking at the volume and the pressure delivered, is trying to synchronize that effort, and the ventilator will make every effort to synchronize and support every breath taken by the baby.
Sorry about that. I don't know what happened. I think I clicked a link.
So what is SIMV mode of ventilation? So really, it's more about a baby who's slightly bigger. You're getting overventilated breaths. Already your CO2 is low, but for whatever reason you still want to. You have to keep this baby ventilated. In that case, you don't want all the breaths taken by the baby to be supported. You want the baby to actually make an effort to sustain that pressure needed to have an effective gas exchange. So whatever that rate that is set on the ventilator, only those breaths are supported by the ventilator. Any additional breaths, as you can see with the next slide, any additional breath is not necessary. So the middle one is these are attempts made by the baby, and actually that is not supported by the ventilator, but it's okay because these are bigger babies and will be able to, there are some ventilators we may need to add in an additional mode called as pressure support to help with those breaths in between, which is not needing, which is not achieving the pressure that is required to inflate the lungs. So I've spoken about different modes. I've spoken about pressure versus volume, and in pressure I've spoken about triggered and non-triggered mode of ventilation, and more and more there is more evidence that if a baby is otherwise well, then volume targeted ventilation is probably a better mode of ventilation, and there is no there's no dearth of evidence for that. So if it reduces BPD, bronchopulmonary dysplasia, the ventilation days, the IH days, and the reduction in deaths as such. And there is Cochrane review to support that. So the outcome of death, the pneumothorax, ventilation days, hypocarbia, and we know that from our own experience, low CO2 in a preterm baby is not good. That is a risk factor for your cerebral vasodilatation, increased IVH. So volume controlled, volume targeted ventilation actually has this protective effect, and that's why compared to how we were with regards to to the number of IVHs we used to have in the past, those we don't see that often. So the overall the neonatal care with time has improved very significantly. So what do we do in volume control ventilation? So we set your volume between 4 to 7 months per kilo. And in addition, what we set is basically the maximum pressure allowed. So that's your safety mechanism. So that would mean that basically if with every breath, the ventilator will attempt to give a set 5 mils per kilo, if that's what you have set. And with every breath, the pressure required could be very different, but there is variable pressure that is needed. But you must allow the ventilator to give that additional pressure that is required to reach that 5 mils per kilo. So on one breath, you may need pressures of 23. On the other breath, you may need 27. So you may need to set your target or the maximum pressure of 27, 28, in some occasion up to 30, depending upon how much the baby needs and the lung compliance is. So let's have a look at this graph. So on the right hand side, I've got a volume to control. On the left hand side, I've got pressure limited. Now on the right hand side, I've set at 5 mils per kilo. And you know that initially, when the baby was actually not as well, the orange curve that you see, that means the baby needed higher pressures to reach that 5 mils per kilo. And with time, as the compliance of the lung gets better, the pressure required becomes less and less. As opposed to on the left-hand side, what you can see is a pressure-limited ventilation. You see that you've set this baby on a standard pressure of 25 over 5. When the baby was unwell, the volume delivered within the lungs is less, but once the compliance of the lung improves with time, the volume that is delivered is higher and higher, causing more volume trauma. So in a pressure control ventilation, the reliance of blood gas and active weaning is significant. And in the volume control, there is this automatic auto weaning that happens. That means basically that there is, with improved compliance, the pressure needed to reach that targeted tidal volume improves with time, and that's why there is an auto weaning. So even if you have not remembered to drop that volume from 5 to 4 or from 6 to 5, that's okay. But the overall pressure needed is less. Overall MAP or the mean area pressure needed is less, and I can explain that in the next slide again. And let's look at this difference. On the left-hand side now is your volume ventilation. On the right-hand side is your pressure ventilation. Now, we're looking at how the volume, the flow pattern that is achieved to reach that pressure. So the flow that is achieved in the volume is a sloping curve. So it does not reach that targeted volume straight away and is much gentler on the lungs as such. So it takes a while to reach that pressure that is needed. It gets that information from the previous flow that is needed. And in a pressure controlled ventilation on the right hand side, you can see that the flow pattern is an upright curve, which means that if you set the baby at 25/05, it will reach that 25 with no problem very quickly. And in an otherwise preterm baby, where everything else is okay in this baby, in that case, it may not be as gentle mode of ventilation for a premature lung. How does volume control ventilation work? It gets all the information from previous flow driven. So it really gets that information from the previous flow. Have I reached that 5 mils per kilo? If I'm not, then I will give increased pressure with the next one and reduce it accordingly. So it has this continuous loop from the previous breath and tries to achieve that volume targeted ventilation that you're aiming for. So the main special consideration that if there is a leak around the tubes, because it gets all the information from the previous flow, Sir, I think somebody is unmuted.
Hi, can everyone mute themselves, please? Thank you.
So if you're really looking at the, if there is a leak there in the volume control ventilation, if you have more than 50% leak, then you may need to change the mode of ventilation. Volume may not be the right mode of ventilation. Or for example, if there is a unilateral pathology like a CPAM or a pleural effusion, in that case, of course, the volume control may not be the right strategy. For all practical reasons, please use the current weight as opposed to the birth weight. So the volume control, it must optimize week on week, and you must change the weight that is set on your ventilator, or the target that you've set is on the current weight or the working weight that you use. So I'm not sure you want me to do the example now, or should we go to high frequency and come back to the example? So let's do, is there only, yeah, so let's just go to high frequency. I'm quite conscious of the time that we are. We quickly, gently, quickly go through high frequency oscillatory ventilation. When I talk about your volume control ventilation, we're really talking about 4 to 7 mL per kilo. Now, what we want to do is, if the baby is getting sicker and sicker, you really want to go up on the mean airway pressure that I was talking about. In that case, you still want to be in the safe zone and yet ventilate this baby. Then high frequency mode of ventilation actually serves as a very good mode of ventilation, because the targeted tidal volume over here is anywhere between 1 to 3 mL per kilo. What we're doing is sudden bursts of the continuous oscillation that is given to the baby, and it works slightly, ever so slightly, in a different fashion. And that's it. So as far as possible, you can see that small, instead of the pressures going all over the place, you'll aim anywhere between 1 to 3 mL per kilo, and it'll still be in the safe zone, and that would be the idea for high frequency ventilation. Now, key targets of volume control, I think commonly we use it for things, conventional, anywhere where conventional ventilation, where your mean airway pressure is keep going up, and that would be the time that you would consider high frequency ventilation. Quite commonly, you will see it with severe sepsis baby or meconium aspiration, and surgical babies like congenital diaphragmatic hernia. But that in a diaphragmatic hernia, that wouldn't be a go-to mode. But of course, we have a low threshold to go to high frequency because of the tidal volume benefits. So how do we set things on a tidal volume? So basically, your IV ratio in most ventilator would be 1:1 or 50%, depending on which ventilator that you use. Common start point of frequency would be 10 Hertz. And if you're converting from a conventional ventilation to your high frequency, have a look at that mean airway pressure, and the general start point will be additional 2 to your conventional ventilation. So let's say on a conventional ventilation, your mean airway pressure was 13, you add another 2 to 15 to go up to, that would be a start point. And amplitude generally will be roughly 2 to 3 times of your mean airway pressure. And another way is basically to look at what chest bounce. If the chest is now bouncing, then you're not giving enough amplitude. And consider increasing a MAP if you're going beyond 3 times the ratio of your mean airway pressure. So if you're 15 of MAP and 45, and yet you need an increased amplitude beyond that, you may need to go up on the MAP to 16 to achieve that. Always trying, aim is to do a chest X-ray straight after, within an hour or so, and a blood gas. That's to see what the chest expansion has been. So, and generally, when you're talking about high frequency ventilation, of what we adjust. Now, mean airway pressure is typically for the oxygenation point of view. So you're really looking at a mean airway pressure, what if the oxygenation is not very good, you keep going up. Your delta P is your power, which helps with and the CO2 clearance is mainly with the delta P and your frequency. So if your frequency is try if your frequency if your CO2 is low, then we increase the frequency. That's because of the tidal volume that is generated. And if it's of course high, then we reduce the frequency. But try whenever you're touching your frequency, try and check with your consultant, discuss with your senior colleague, because frequency is something that we I as a consultant always would like to be involved in that kind of a decision making, unless of course it's very clear, the CO2 is low, we need to go up, or the CO2 clearance, you want that to be getting better, so you reduce your frequency to clear faster clearance of your CO2. Again, always look at this is once you've done a high frequency, look for signs of on your X-ray, look for signs of over distension. So you're looking at, in this case, you're looking at a narrow cardiac silhouette, your diaphragm dome flattened out, you're having more than 8 posterior ribs. All that is an indication that your mean air pressure is probably high, and if your mean air pressure is that high, you may need to drop it down. Otherwise, you will have systemic your venous return reducing, and your blood pressure actually much lower, and need for inotropic requirements might be higher. So if you drop your mean air pressure, your blood pressure will improve automatically because you're not squashing the heart as much. That's about it. It's quite a whistle-stop tour about quite a lot of topics. I'm sorry I went overboard. I've got 2 gases if you'd like to discuss, but it's totally up to you. I'm open to questions.
I can't see any questions in the chat. I mean, if anyone has any questions, feel free now to type. But if no one has any questions, I think now could be a good time we can go through gases and the cases that you put up.
Yes. Okay. Should we do that?
Yeah.
So let's start with the first one. So I deliberately put very few cases so that I was quite conscious about the time. Sorry. So if we go back. Okay, so patient 1. So you've got a newborn baby, 27-weeker, and that's your blood gas. This baby is just born, and the baby is ventilated, so is on PTV. That means all breaths are supported, and that's your blood gas, and that's your pressure that is required. Can you fire away with some of your thoughts? These gases or numbers are deliberately written the way they do.
So if anyone wants to write in the chat about what they think about this gas. So yeah, we've had, okay, so we've got one person saying consider Curasurf, and another one saying has the baby had surfactant in this situation?
Not had surfactant, so I can see the chat, so thank you. Yes, now we've heard a lot about conventional ventilation, so there was no surfactant given. Yes, we must think about surfactant. Yes, anything else? Somebody's written about increased PEP, but I think your thought process is coming from the CO2 being on the slightly higher side. The increased rate, the rate is already 60, so it's quite a high rate. Where you wouldn't be going any higher. In fact, you want to change to volume guarantee. Yay, that's a very good answer. Okay, so yes, it's a preterm baby, so you want to surfactant is a very yes, and examine the baby dope, absolutely. So if you're worried about the baby, but the oxygen requirement is not as high, it's 0.4. So initial trial of your surfactant. Shall we go to the next slide and see how that goes? Yeah, so this baby has now been given surfactant, and that's your CO2. I'm sorry, ignore the numbers in the bracket, but no, consider the numbers in the bracket. I don't know. So that's your pH of 7.6, PO2 of 10, so that means oxygen level is very high. PCO2 is 1.5, it's quite low. And the ventilator mode is still on CMV, and the oxygen requirement post-surfactant is very good. It's come down to 21%. So what are your thoughts? And the rate still remains high. And somebody with the previous slide has said, don't increase the rate. Of course, we can't increase the rate, and we can, yes, reduce the rate. Anything else? The CO2 is very low in there. I'm waiting for Amira to repeat that answer again. Okay. So Amira, increase your eye time. Now, increasing your eye time. So what would that do? So that will actually cause, it may not be a sensible plan into increasing eye time. Eye time on being low, we know that in preterm babies we keep lowish eye time, and it can vary between 0.36 to 0.4. But increasing in the concept of low CO2 may not be sensible. Your oxygenation is very good. So actually considering volume guarantee is very good. There is some suggestion of using a SIMV. Now, in a preterm baby, it really depends on which unit you're working. Volume guarantee, and how much of volume guarantee would you set this baby at? Or volume targeted ventilation. So how much would you put it at? What would be the tidal volume that you put this baby onto? 4, 5, yes. So, so you know, having 5 mils per kilo as a rough start. Now, what's the huge advantage of putting this baby onto volume control mode of ventilation? Because that will solve your problem with low CO2s and over-ventilated gas. Because as I said previously, this over-ventilated gas has a huge risk for this baby. And why might that be? The CO2 being 1.5. IVH, and what is it? What is the thought process? Why do you think there would be cerebral bleed, and why would that be, Polly? Low CO2, IVH, yes. Well, yes, exactly. Cerebral vasodilatation, and you will have. So the key thought process around any kind of bleed within the brain is mainly it's mainly around changes in your cerebral. It's the changes in the perfusion within the brain happening quite rapidly. We know that the capillaries around your ventricles are quite fragile, and they blister. They open up quite quickly. And it's important that we don't, have this gases saturations on a higher side in a preterm baby. Obviously, why don't we want saturations on the higher side in these babies? Yes, so we've got that right. So we've got for ROP reasons we don't want the saturations to be high. And we want and cerebral vasodilatation, as you said, like the perfusion gets you want to get absolutely right. So if you set it at 5 mils per kilo, the pressure will auto-regulate to deliver that 5 mils per kilo. In that case, you're not worried about, is it 20 of pressure that I need? Is it 18? Is it 17? It may just be the baby needs only 14 or 15. In that case, you've done the right thing. Question whether should it be a SIMV or PTV mode on a volume control. Now that's a questionable one. Quite often we still believe that all breaths should be supported in a very small baby. You don't want them to get tired out. It's almost never a good. Would you extubate this baby at this point? Well, because of the over-ventilated gas, the oxygen is good, the PO2 is good. Yeah, so there is some and why would that be? Exactly. So Michelle is saying that should we wait for normal CO2? Now, what happens with very low CO2? It cuts off your respiratory drive. So it's important that we bring that CO2. So avoid a fair amount of time on your volume control. Ensure your gases are supported, and if there is enough trigger, so my type of plan would be volume control on a patient trigger mode of ventilation. And then see and ensure that the rate is right down, because it can be as low as 40, and because every breath beyond that will still be supported if you're on a PTV mode of ventilation. It's just that if the baby is breathing above 60, and your backup is 60, but then you may not necessarily know how much additional backup rate is needed. So the good strategy, volume control, reduce that rate, put it on PTV mode of ventilation, get a normal gas, and plan towards extubation if the baby is otherwise all right. Are you happy with that explanation so far? So Farah is asking, are there any ventilators which have got restricted modes? But I'm not sure. So when you say restrictive, you mean restricting among the pressure modes? You're probably asking that question. So on a pressure, I can't do PTV. I'm not sure I follow that question. So basically what we're looking at, you can on a restrictive, you're restricting that 5 mils per kilo, keeping that Pmax on a reasonably high, so that that ventilator allows you the pressure, and you can or you on a PTV mode, if you want a pressure mode of ventilation, you can limit the volume on some of the ventilators. So you can do both ways, either way. Okay, shall we go on to the next gas? There's only one of the gases that I've kept up. Okay, let's just go on to the. Thank you. So look at this baby. You've got a 27-week newborn baby, and it has got prolonged rupture of membrane, and that's your gas. And can I just add that it's an arterial gas, that's your pressure, which is 26/5, mean ever pressure of 13, and the FI2 requirement is 100%. Are we worried about this baby? And the CO2 is quite high, it's 11, and it's a newborn baby, just to say that. And there is prolonged rupture of membranes. Okay, so we're all worried about baby. So very sick baby. In other words, we are worried about sepsis. Am I right? Okay. Can you talk me through your strategy of your thought process in terms of how you do? Okay, I know we're all talking about high frequency. There's a lot of answers around high frequency, but can you do this? Yes, surfactant. What are we dealing with this patient? So you've said PPHN, underlying cause. Selva, you've said a lot of strategy over there. So essentially, we're talking about possible sepsis with PPHN. Calculated OR is a good one, and it could be. So basically, we're looking at a very sick, unwell baby. In that case, can you talk me through if you and there is nitric oxide being thrown in as well. So basically, this is a sick baby. So we're really looking at. So I would, there is some suggestion of ECMO. So let's just take one step at a time. So this is a baby. Clearly, the ventilation strategy is not working. You've decided to change it to high frequency. What is that map that you're going to set at? $15. So we're going to do 15. That's because we've got an earlier map. That will be a good starting point. What is that frequency you're going to set at? 10. That's a good start point. And what is the amplitude that you're going to set at? Okay, we've got 45. General answer is basically yes, it could be up to 3 times or until the chest bounces. So really, so 30 to 40 is fine until the chest bounces. And what will you do? And what we best part is to let the baby settle down with that. Look at what your blood pressures would be. You may need to have sighted an arterial line to look at what your blood pressures are, because it's very likely you may need some inotropes because you're dealing with PPHN and the sepsis baby. You may need multiple inotropes, and that gets sighting in either an umbilical or a long line. It's a newborn baby, so umbilical line is probably easier to manage that way. And getting an X-ray straight after that, because you want to do an X-ray because of we'll do an X-ray straight after connecting to high frequency, because yeah, exactly. So you want to make sure that your mean airway pressure is reasonable. You're not over-ventilating, over-expansion, and over-expansion, as I said, you're looking at. And of course, pneumothorax, hopefully not in a high frequency unless you're giving too much MAP. Yes, 15 is high, but the whole idea, as I said, like in a high frequency, you're doing lysotypal volume. So hoping with the whole idea is conventional ventilation is you're not going up and up on your conventional ventilation to blow a pneumothorax. Yes, pneumothorax can happen in any of these babies. So nitric oxide simultaneously working on, you may need your inotropes, and you have to consider your arterial gas and look at what your PaO2 response is and see whether that is improving. Always remember, you have to maintain pre and post ductal saturations, because now if there is a wider gap between your pre and post, then you're looking at managing a PPHN baby, and in which case, of course, you may need some fluid, you need inotropes, and yes, of course, you need to calculate OI. You have to monitor this baby carefully. Are you happy with that answer? That's about it. And thank you so much for your time.